Right. Well, let's get this party started. Give me a minute to get myself set up here. Put you over here. Let me get out of my face. All right, beautiful. So before we dive in, I want to frame what this folder represents. This is not just documentation. This is not just busy work. This is a blueprint for scalable, school-based diagnostic equity. At a time when national infrastructure for bleeding disorders is being dismantled, especially with the CDC cuts to surveillance and genomic oversight, we need state level leadership and innovation more than ever. And this project directly steps into that gap. So, what you will find here is a rigorously structured, evidence backed, and implementation focused model designed with some of California's most underserved students in mind. And it's important to note right off the bat, there is no reason to do this project halfway. In fact, we would be setting diagnostic equity and the future of comprehensive healthcare inclusion in California back by doing so. So, yes, this folder certainly has a lot in it, but it has to. To anyone watching this, I know you probably have a busy schedule, um, a lot on your plate, and your interests might not be all that aligned with every facet of this work, and your priorities might not be directly aligned with the entirety of what's included in this folder in this project. But we can sit here and confidently say one thing, that a program like this, if you do half the work, you are not entitled to half the results. We are going to have to commit to this in our given roles and this initiative in its entirety. So what you will find in this folder is a full literature review to ground the clinical and public health necessity, a detailed justification of cost effectiveness and downstream savings, strategic integration into existing state funding streams, detailed publication strategies, and critically, real-world insight from school nurses whose participation this program is built around and whose ongoing feedback will continuously inform and catalyze the embedded program evaluation and needs assessment that will ensure that this initiative is relevant, reproducible, and has an element of long-term stability to it, sustainability, either way. So it's not a theoretical. This is aligned with California Youth Behavioral Health Initiative, CYBHI, California Community Schools Partnership Program, CCSPP, Student Behavioral Health Incentive Program, SBHIP, and Local Educational Agency Medi-Cal Billing Options Program, LEABOP, and the evolving role of school-based health centers in California. Those four initiatives being an important part of that in general. So whether or not you're here as a policy decision maker, a public health official, a medical official, or an educational leader, this folder anticipates your lens, and it offers a pragmatic, equity-forward solution to a solvable problem and the infrastructure to move it from pilot to policy. This initiative builds on over a decade of rare disease advocacy, education, and lived experience. As someone living with a bleeding disorder, I have spent the last 12 plus years working with both the state and local National Bleeding Disorder Foundation chapters, including the last 2 years as a statewide ambassador. In parallel with this specific project, I'm preparing to present an abstract on point of care ultrasound for hemophilic arthropathy at the 2025 National Bleeding Disorders Foundation Conference, and was recently accepted into the 2025 American Society of Hematology Advocacy Leadership Institute in DC. And to top that all off, I'm a second-year medical student at Toro University of California in Vallejo, where I'm also finishing up my Master's of Public Health in a few short months here. All these roles represent a lifelong investment in changing the diagnostic and care landscape for bleeding disorders, not just at the policy level, but within schools and community systems where early detection can shift lifelong outcomes. All right. So looking first at the folder, and I know it's a lot. And although you could certainly make your way through this at any old rate and be perfectly fine, it is organized for that purpose. It might be quicker and easier to just have me walk you through it. And my guess would be that's why you're this far into the video at this point. What I've also done critically is leave timestamps on this video, which will highlight exactly where I go over every ounce of this. So you can skip ahead, return to important parts, skip over parts that aren't relevant for you, etc. Also, critically, I made this roadmap down here. Oh, we're already on it. Sorry. This is the folder itself. The roadmap's down here. Also made this roadmap specifically to also be a pretty straightforward way to work your way through this folder. So that'll also be the approach that we take here through this video. It's a very straightforward way to just get us from start to finish and make sure we've gone over everything. So the first thing we'll see here is the public health grant strategy for a medical student lead. So I'm not going to go a lot into this folder. There's not a lot going on in this folder. And my hope would be in the future, this initiative is not reliant upon cyclical funding, subject to external variables, year-to-year funding fluctuations, and unstable or otherwise influenceable political dynamics, as we now know. So for the time being, this spreadsheet has a list of some of the biggest and most closely aligned funding opportunities for an initiative of this sort in California. Some of them can be applied for by 501c3s, like the local NBDF chapters. Some of them pertain a little directly more to medical students or public health students. The idea being that some of these grants could serve kind of a dual supportive role to both support the initiative financially and to also have someone either constantly doing research with the data derived from this initiative and slash or constant program evaluation and needs assessment to make sure this initiative is effective. So either way, some good grants in here. These don't include any of the like bleeding disorder specific pharmaceuticals like Takeda and BioMarin. Those are not included in this. And then what the Word document does is just goes a little bit further. It kind of explains the approach to some of the public health and medical student accessible grants specifically in further detail. It has a little context on each opportunity, some pre-written grant language, and overall just more information to try to increase the likelihood and ease of future reproducibility in grant funding. This is one of the few areas in this folder that I'll say I still have a little more work to do. But again, the hope is that stable, large donor or even governmental, multi-year financial commitments relieve the necessity of at least the nonprofit running this initiative from having to spend time and resources on securing annual funding, filling out funding requests. Hopefully, ideally, enough to also support, a public health or medical student or a researcher from having to try and seek external funding to serve as their stipend for working on this. So my hope would be that would be the future movement here, but we will see. So I'll click out of this and I'll always just work my way back to the roadmap. That's probably going to be the best way to do it. And then next I'll go into foundational background materials. So what this is again, like many things in this folder, I tried to design it to be optimized for quick comprehension. So basically, this is a summary of what background information supports this initiative in a very overarching way. And this specific document, like many others in this folder, serves to explain the things that were bulleted underneath it on its hyperlink back in roadmap. And I'll go back over that in a second. But again, the point is that this allows you the ability to just go over a summary of this, or you can get super granular with how far you want to look into the work that I've done. I just want to give you the opportunity to read the summed up version if that's a little bit easier for you. So what the foundational background materials document that we're looking at here does is it lays the groundwork for why this initiative matters, both clinically and structurally. I'm using resources from the California School-Based Health Alliance, the CDC Reductions Mobilization Playbook, the United States Hemophilia Treatment Center Network, and the pilot study to this, which was the Girls and People with Potential to Menstruate with Bleeding Disorders toolkit that was put together and facilitated by the Western and Eastern Pennsylvania Bleeding Disorders Foundations. So it opens up with a pretty hard reality. Diagnostic delays in bleeding disorders, especially among adolescent girls and menstruating youth, are not just long, they are systematically embedded. The CDC's own estimates point to delays of up to 16 years from symptom onset to diagnosis, something that all the literature I found supports. What's worse is that recent budget cuts, like the previously mentioned CDC cuts, have only made early detection harder by weakening national surveillance infrastructure. And this context makes it clear. If we want to change outcomes, we have to move upstream. This document then makes a little bit of a pivot to address who's most affected and why. It highlights how girls and menstruating youth are often misdiagnosed or have their symptoms often overlooked as red flag opportunities like long, heavy, or painful periods get normalized or brushed aside despite their potential link to underlying bleeding disorders. It walks through how our current specialized care network, like the hemophiliac treatment center networks that connect all the hemophiliac treatment centers, are absolutely phenomenal, but they only kick in after diagnosis. That's why schools, especially those with school-based health centers, SBHCs, become such a powerful early detection site. The rest of this document outlines how this initiative strategically braids into existing California state funding systems, like some of the ones I previously mentioned, CYBHI, CCSPP, SBHIP, and LEABOP. And what that does is it makes the program financially sustainable, scalable, and fully aligned with state equity and pre-existing health infrastructure priorities. It ends with a clear call. The tools already exist. The problem is identified. This is the blueprint to finally connect them. And like usual, throughout this document, that is, if you want to go further into any of these cornerstone resources, in this one specifically, I have little summaries of each of them here in each of these tabs. Again, what is a school-based healthcare center, CDC reductions playbook, all of this stuff. It's all linked right here. So you can read these little summaries if you want, or like I said, you can read them all in their entirety as they're all down here. Right. So next up, let's get into this full literature review here. All right. So the academic in me wants to read this out in its entirety. But I will avoid that. In lieu of that, I will note now that you've at least started to see the background, the foundational background for this program. You at least started to hear about the depth of the issue. I want to at least highlight that what a literature review does in this sense is it deeply anchors so far a philosophical idea that we've identified through evidence-backed research to a deeply entrenched public health gap. That's what a literature review. It blends those things together so that this, again, moves from abstract to tangible reality. So what this review pulls together is a very clear, urgent picture of why bleeding disorders in menstruating adolescents, especially in our rural and underserved communities, are often missing or misdiagnosed for years. So we start with the diagnostic delay that was previously mentioned, but here for redundancy is between 10 and 16 years from first symptoms to diagnosis. It's a decade or more of heavy bleeding, missed school, untreated anemia, and serious psychosocial stress. This is more than just a simple clinical oversight. This is a systemic failure rooted in bias, much of which is genetic. Again, hemophilia often being X-linked in many healthcare providers, thus inappropriately assuming that it's mainly in young boys. It's in young women as well, too. Stigma and inadequate primary care screening, which is an all too common issue in common modern primary care physicians. It's just an unfortunate issue we're dealing with in general. When we start to zoom in on some of the social determinants, one really critical one that shows up is geography matters. Rural students often face much longer delays, fewer referrals, and less access to hematology specialists and hemophiliac treatment centers. We also know our population, and at least here in California, they are largely of Latinx descent. In fact, as of June of 2025, that demographic reality carries a really important implication. Many of these students may be undocumented, and as of now, 55 to 60% of the K through 12 student population in California, especially in rural and underserved areas, are of Latinx descent. Fortunately, under current state policy, undocumented youth remain eligible for full scope Medi-Cal coverage, which means proactive school-based identification and referral is not only possible, but ethically, financially, and logistically imperative. Beyond that, there's also resources available through the California Children's Services, CCS, pharmaceutical manufacturers, third-party charitable funds, and through the regional NBDF chapters. And it's also important to note that all this goes for anybody else who pops up through this initiative with red flag symptoms, gets referred, and gets diagnosed. It's not just going to be undocumented youth, but it's an important demographic to really highlight here. The this review then shifts towards solution design. We focus on school nurses and school-based healthcare providers, not just as bystanders, but as linchpins for early detection and far upstream gatekeepers of clinical diagnostic suspicion. And for those of my medical colleagues who are listening to this, we know how important clinical suspicion is, and early clinical suspicion, especially when we're talking about zebras, not horses. They've already built trust with students, the school nurses, that is. We know how important that rapport is, and they already notice things and patterns like frequent nurse visits or repeated absences during menstrual weeks. We need to leverage that clinical insight that they possess. These school nurses, they're smart, they're intuitive, and they're poised, as many women may know from personal anecdotal experience, to be the first or one of the first to notice abnormally heavy flow in one of a young girl's first menstrual cycles. I should also be saying people capable of menstruating. I want to be inclusive with my language here also too, but I don't want to get bogged down with that as well. Returning back to it, these school nurses, they're under-resourced and they are under-recognized, and that is a large part of this initiative. That's why this program invests in their role, as you'll hear a little bit about later, and why the literature directly supports equipping them with structural screening tools, clear referral pathways, and trauma-informed menstrual training. Finally, the review ends by making the case, as any good literature review does, for implementation. Why California is the right place? Why now? It cites successful models like the WGPPN pilot study, that was the Eastern and Western Pennsylvania study, to show that structures for early detection programs aren't just aspirational. They're able to function directly in settings like this. So overall, the literature review is more scaffolding. It's where we've pulled together the clinical urgency, the systemic inequities, the role, the leverageability. I don't think that's a word. We're just going to roll with it. Well, if not now, it is school-based providers and the public health infrastructure already in place to support this work. It exists. It exists. We just need to tap into it. We need to leverage it. So this review itself, it's only 3 pages. If you want to give it a go, it proves that I'm not guessing here, and it proves that we're also building from a strong evidence-based foundation. So it's in here. Full citation list as well, too. It's about 40 articles. As mentioned, some of them pretty landmark in this very specific, nuanced space. But yeah, all the full articles are in here if you decided you want to go through them. All right, so working our way down a little bit here. This is some of the stuff I talked about. These are the, these were linked in the foundational background materials, the CDC's reductions, Hemophiliac Treatment Centers Network. This was the pilot study. We'll talk a little bit about the REST integration later. And then the SBHC, school-based health centers, is a really important one to kind of know how these work in California. These 4 initiatives that I talked about, here's a link to all their websites, the lead agencies that run them, kind of the main purpose of each agency, and the relevance. Okay, beautiful. So next up, here's an important one. But again, this is a proposal. I definitely want to say that right off the bat. There are many ways to get this done. As I elucidated from the literature review, another angle of this initiative is how it aligns with broader systemic needs in school health infrastructure, particularly the chronic underfunding and overextension of school nurses. All right. So the previously mentioned diagnostic delay crisis in inherited bleeding disorders is a structural failure and thus requires a structural solution. Even in the absence of confirmed diagnoses, this program improves day-to-day care for many students. School nurses are often the only consistent healthcare touchpoint for menstruating students, especially in underserved districts, and they are stretched thin. So this program doesn't just serve adolescents with undiagnosed bleeding disorders. It mutually uplifts a long overlooked workforce by formally acknowledging their diagnostic role and incentivizing their participation in broader integrated healthcare in ways that are pragmatic, respectful, and scalable. So this document specifically lays out a tiered incentive model with 3 core components. A flat participation stipend for nurses who complete their minimum requirements. That's how we're collecting our data. An early submission bonus to both accelerate early engagement during this program's launch phase and set a precedent for data collection in general. And then C, A parallel track raffle system is not wholly necessary, but could be viewed as another approach to keep things flexible, maybe for students who can't commit, I'm sorry, for nurses who can't commit to data every single month, or even as part of an approach to gather insightful qualitative data, which we'll talk about a little bit later, that might require a little extra incentivization. We will see. But overall, the structure is intentionally very low burden. I'll show you the forms a little bit later, but they're all monthly drop-down Google Forms that take literally minutes. Um, they have predictable payments, modest but meaningful amounts that can support both personal motivation and program-related costs, like health supplies, something that we know that these nurses are chronically underfunded in. Again, that's part of that dual support role. So what this approach accomplishes is twofold. First, it ensures the continuation of our data collection and student engagement, both of which are vital for both diagnosing bleeding disorders early and justifying future program funding, if we're being perfectly realistic. But second, and perhaps most strategically, it creates a replicatable blueprint for how to invest and elevate school nurses as central figures in pediatric public health. Let's view them as such. This is not a one-off project. It's designed to seed a sustainable, self-reinforcing infrastructure where school nurses are empowered not just as implementers, but as co-developers, health equity advocates, and contributors to the betterment of children's overall health. That's what they want to do. That's why these people are in these roles in the first place. Let's let them actually feel that they're playing that role, because they should be. It helps everybody out that way. So by financially and structurally validating their time and insight, this program doesn't just treat nurses as bystanders. It treats them as the linchpin partners that we want them to be. And that distinction is everything. All right. So everything here again, in this specific folder, it's just a set of numbers. It's really important to note that these are a set of numbers that apply to an underlying chassis. And the underlying chassis is what's way more important than the specific numbers, right? I mean, we can play with the numbers, and that's part of why I didn't even go as far to put this into a spreadsheet. Because what I did want to do at the very least is just play out these numbers, this infrastructure, in a hypothetical way that we can just learn from really quickly here. So that's what I did. So let's say, for example, you just took my numbers, which, 75 a semester, 150 for this flat stipend rate, right? Let's just roll with that for a second. If we were to do that, we'd be incentivizing school nurses at a pretty high cost. It'd be about $37.50 for 25 schools. Ratchets you up to about $150K for 1,000 schools. That's a big number, and I understand that. So what I wanted to do was, this is an interesting way to approach it. But if you can hang with me here, how this chart works is it's a negative percentile chart. Okay. It's negative percentiles based on these two numbers, this 3750 and this 150K. So let's say, I only want to pay about 10% of this. So I'm going to subtract 90% of it. That gets me down to $375 for 25 schools, or a pretty modest 15K for 1,000 schools. And for referential grounding, these two numbers correspond to paying a school nurse about $15, a participating school nurse about $15 a year. So pretty small numbers there. So yeah, that was just option A. So if we look at option B here, for example, you're getting the same exact sort of chart, but we're rolling with the early submissions in addition to that flat stipend. So you got your 5,000 for 25, your 200 grand for 1,000 schools. That ratchets, down to 500 or 20 grand if you're only paying out, 10% of this 5 grand. And then we get into option C. Again, all hypotheticals. I feel like I should keep saying that. But if you rolled with options A, B, and C all congruently, you'd get something that runs you on the high side, about $6,200 for 25 schools, or $250,000 for 1,000. Again, if we stripped those down, we could end up paying a lot less, really only about 25 grand per school. But it's really important to note, another form of contextualization here, that this is just $250 extra per school nurse per school. So if you look at it that way, it's not a crazy number. But again, these are all very highly modifiable numbers, which is why I did not want to sit here and set these in concrete. I just wanted to use these to play around with a very realistic ballpark of, again, up there was $15 per school nurse all the way to $250 per school nurse per year. So it gives us a ballpark of what we could be paying because I feel like that's probably the ballpark we'll be in. But hey, I'd love to give them more. They would love if we could find a way to give them more. Um, all right, so then back in and back out to my roadmap. The next thing we'll get into is the data collection system. So these are two things that are currently in iterative development pending further stakeholder input. So if I click on this dashboard slash tracker here, this centralized dashboard, rather, sorry, this just gives me an idea of where all my data is going to come in. Okay. So this dashboard tracker, so this is eventually where I'll integrate all the survey responses from Google Forms, including the diagnostic tracking intervals, which are part of the REST guidelines, which we'll go into a little bit later, and the outcome metrics into a live auto aggregating Excel-based dashboard. We'll see here in a minute some of the questions on the surveys. I'll show you those. But for the most part, they address time to diagnosis, quantitative outputs like referral rates, geographic and equity-based insights that include more rural school participation and include identifying barrier care for families. And I'll go into a little bit more why that's important, but those are very classic kind of public health metrics. Another reason I've kind of left it alone is because the best option might be create a de-identified HIPAA compliant folder that might just be stored on a cloud for HIPAA compliant reasons anyway. So for the time being, the actual responses all find their way to the centralized dashboard anyway. It just takes a little extra legwork, but they're all still in here, so it doesn't matter. And then for the reporting and dissemination portion of this, also incomplete until we have a full list of stakeholders. This will be the places that we do formal reporting and dissemination pathways to make sure that we're accurately reporting on the data that we collect on this initiative to those involved. So, I mean, these outputs could include things like quarterly reports for implementation partners, policy briefs to support legislation and agency engagement, or academic presentations and journal articles, which we will certainly talk about a little bit later. I'm anticipating routinely sending information to agencies like the CDE, CDPH, the Hemophiliac Treatment Centers, maybe even the Hemophiliac Treatment Center Network, potential funders, research collaborators, and national advocacy organizations like the NBDF. But that's just my current guess, and my hope is that there's more. All right, backing my way all the way out, centralized dashboard, where everything's coming in. Here we are, through a lot of stuff. Now we're into the actual kind of meat and potatoes of the data itself. So the monthly contact points with school nurses. So this is the core survey at the heart of this entire engagement strategy, as we talked about in the nursing incentive section. I certainly emphasized there, as I will do here, the critical importance of this single recurring data source that will shape our understanding of real-time needs, impact, diagnostic trends, maybe a little bit better way to look at that. And most important of all, something to never lose sight of, referrals. Actual clinical referrals to GPs, specialists, HTCs, and the local NBDF chapters. If you're interested, you can click into the actual survey, see what they have to offer. It's built to be really quick for the school nurses, like I said, part of their workflow, 2 to 3 minutes, not very much. In fact, I'll just go into this one super quick. School name, school district, your name, month and date of this log entry, how many packs did you give out? Did any students actually get red flagged? Did you send them a follow-up? Stuff like that, right? Very straightforward. What we got? 10 total questions. Hope would be that's about 2 to 3 minutes a month for the nurses to do. That would be the hope. Okay, so let's say we find a red flag. Let's say we got a referral we make. So simple. What this sheet does is it shows what happens if a school nurse indicates that a student has been referred for medical evaluation. A follow-up protocol is triggered, as you might expect. And what is sent out is the referring nurse gets both a 30 and 60-day survey, in addition to getting contacted by the local NBDF chapter to try to make sure that follow-up has occurred. That 30-day check, have you followed up? That 60-day check, has that family seen somebody? And then your local NBDF chapter, hey, do you need me to step in and be a patient advocate here? Just to try to be very polite about the fact that we don't want referrals to fall through, and we have ways to take the burden away from the school nurses once that diagnosis is made. So again, these two 30 and 60-day referrals are the exact same thing, just double checking with that nurse to make sure that a referral was made and the process has started to take shape. That's all we're getting after there. We will also get some really good qualitative data out of this. This, in addition to the family follow-up survey, we'll get information regarding things like difficulty in scheduling appointments, finding providers, language and literacy barriers, insurance issues, all things that are, again, really important in public health, that can all inform system-level equity improvements and grant justification, and a number of other things. It's just very critical, good insights to always be paying attention to. So again, that's the diagnostic referral pathway. There's your follow-ups. There's your family engagement. Again, the only reason I wrote that as optional is because I would love to be able to say it's not, but technically we need to make sure that it's okay for us to be in contact with the families from the school, and we'll have to make sure that we get permission in that regard. So hopefully we can get some good qualitative insights from the nurses, which leads me into this last little bit here. Yeah, because the last survey is really important considering it's what informs our program evaluation and needs assessment. So which many of you know, especially if you're in public health, you know that a public program evaluation needs assessment is a really critical part of any public health campaign. And what it does is it helps ensures that this initiative remains responsive to school communities' most genuine needs in a way that is sustainable and works across many settings. So central to this process, like I said, is the school nurse program feedback survey, which will be sent out hopefully every semester to capture more quantitative, but also critically important qualitative insights. This is important consideration because this program is centered around the insights that we're going to get from these school nurses. And the adaptive refinement strategies that we engage with will be critically based around the insights that we get from these nurses and will also be critical parts of the strategic scale-up justifications as this program builds. And again, like I said, because that qualitative data takes a little more to get, again, I think I anticipate that this survey is a little more like 5 or 10 minutes. You got to type out a couple things. A couple of them are just clicks just to make life a little bit easier for them. But the assumption is it takes a little more time, so we might have to, again, engage with like option C back in that school nurse incentivizing program where we're giving a little bit more of an incentivization to give us a little more data like that. But again, things that we can address a little bit later. All right. So again, a lot of surveys for the nurses, but they're all very deliberately low stress. Really only 3 of them. You could argue 4 if you want to count this as 2, but it's the same survey twice, and they're all Google form dropdowns. Very basic, straightforward, low burden. That is certainly the idea. All right, next up, we move into data flow architecture. So what this does is this outlines how we'll be collecting data and managing that data. It's the playbook that shows the operational pipeline that enables the outcomes that we get to be tracked with reliability. It specifies who collects what, when, and how the data moves through the system. For example, like school nurse logs to centralized dashboards, because that protects our traceability. It protects our follow-ups, and to make sure that we have real-time feedback loops and things are not slipping through the cracks. The outcome, and again, it's all in here. Again, the period packs log, right? So it's all in here as well too. All hyperlinked just to try to make life easy so you can see where everything's folding into one another. The outcome metrics section, on the other hand, so what this does is this defines exactly what success looks like and why the outcomes matter. This is kind of the scorecard that captures engagement, like the packs distributed, the nurses reporting, along with all important clinical wins, like the time to diagnosis, confirmed referrals. They're all aligned with the REST publication standards. I've said multiple times we'll talk about later. I promise we're getting there. But in general, the way you could kind of think of these two, right? Tier 1, operation and engagement. Tier 2, actual diagnostic and clinical metrics, kind of differentiating those in a way that's kind of important. Qualitative metrics versus quantitative, things like that. Again, in summary, looking between the two of these, data flow architecture. This is how we capture and manage the data to measure outcomes effectively. Outcome metrics are what we measure and why it matters. That's the difference between the two of those. Okay, next up. Publication strategy and research dissemination roadmap overview. This section lays out how all the data and the lessons from the initiative will be shared beyond the schools themselves. This can be to researchers, policymakers, coalitions, associations, other NGOs, public health leaders, a lot. As you've figured to this point, this initiative is being intentionally very well studied. It's a multi-study site with a mixed method design, both numbers, quantitative, referrals, diagnoses, and narratives, qualitative, nurse feedback, case stories. The goal is to publish these in respected journals, present at top conferences, and create policy briefs for decision makers in education, health, and legislation. There is a clear timeline for data analysis. I got the timeline down here, which again, modifiable timeline, but clear timeline for data analysis, poster submissions, and manuscript drafting, ensuring that all these findings lead to tangible, influenceable outcomes. All right. Yeah, this is a strategy that is emphasizing the bigger picture, which in this case is restoring at least some surveillance capacity after the CDC cuts. And can position this as a program that can sit in schools as diagnostic hubs. An unfortunate reality, but at least someone can step into this void and offer a solution. That's kind of the idea. So in short, this shows that this is not just a simple program, it's a nationally relevant public health model that serves as a roadmap to ensure it gets attention, funding, and the replication that it deserves. That's why we have to disseminate this information. If any of these particulars interest you, what I did was I made sure there's more in each. So, like for example, if I go into my proposed outcomes and targets, like this document goes into some of the very specific conferences that I will be targeting in the coming years, and should also represent like the public health grant initiative studies, continued touch points of profound relevance to an initiative and subsequent study of this caliber. The goal is to be in front of people that look at studies like this, that evaluate studies like this, that support initiatives like this, that support the outcomes that initiatives like this get people to. So this is one of the important ways to do this. This is a multi-channel strategy for sharing the program's findings with what I believe to be three really key audiences: academics, policymakers, and public health advocates. Each component here is designed to maximize the credibility, reach, and practical impact of this initiative. In the poster presentation section, I've identified 4 major national conferences that I myself am going to try to target for early dissemination. And these venues span from rare disease advocacy, like the National Organization for Rare Diseases, who I have worked for in the past, their national conference, hematology conferences, which I'm already quite aware of and already attend, and bleeding disorder focused public health. These posters in this current iteration will serve as the first and most important wave of visibility, designed to show the early results, attract collaborators, and generate buzz in clinical and advocacy spaces, something that I'd like to think I'm pretty good at, and that with good data, I can do well for us in. The manuscript submissions are pushed out a little bit further, which will allow me or others time to target peer-reviewed journal publications, and will also serve as the long-term vehicle for academic validation. And that's really important. I want to make sure this is rooted in academia as well too, and accepted there as well as it is in the public health spaces. I grouped these journals into major categories like pediatrics, public health, school health, and why not osteopathic medicine, so that findings can work their way into many different professional audiences. So it's definitely not an exhaustive list of journals, but it's certainly a jumping off point that is indicative of strategy designed to match the multifaceted nature of this project, being clinical, community, educational, and policy facing. I think the last thing in here, last thing in here is the white paper and policy briefs. So what these are here for is these are non-academic, high-impact documents that we would aim at funders, regulators, and legislators, and they'll be used to directly advocate for policy changes, funding streams, or integration into existing infrastructure. Again, like I said earlier, recipients include like the California Department of Education, California Department of Public Health, federal partners like the Health Resources and Services Administration, HRSA, the CDC. I want to say HHS, but at the current moment, I don't know if anyone over there is still literate in medicine, so we might have to skip that one. And state and regional hemophilia organizations and legislators who will inevitably have the final say in actually shaping education and public health budgets. Should go without saying, my surgical approach to these specific publications is to build on the themes of diagnostic equity, cost savings, and sustainability, which should be able to translate this project from a second iteration pilot study to a scalable public health solution. That is the idea. All right. I guess the last little nuance in here is this publication timeline concept. And again, this timeline could change depending on a host of factors, but it's important to note that a robust timeline executed year over year is one continuous year and year is one way to continuously support the feasibility of long-term integration with larger stakeholders, right? And prove that there's a deliverable, thought out intention behind every move, that we're not just kind of winging it year in and year out and just getting lucky and getting funding, that we are doing this consistently year in, year out in a very replicatable and reproducible way. So again, changeable, but that's the main idea for the publication timeline concept. I'll get us all the way back to the roadmap. So if you've been with me this far, started to see a little bit of redundancy across some key issues like diagnostic delay, early detection, cost avoidance, and CDC infrastructure collapse. I promise you this is not a weakness, this is a strength. It's really important in strategic documentation like this that different audiences still walk away with the same core message no matter what. So what that actually kind of looks like is a policymaker skimming a white paper from us, a policy health official reviewing the dashboard model, or a conference attendee reading a poster while I'm standing in front of it, all need to walk away with the same critical core messages. And repeated emphasis of those main points is what makes them stick. So what this section articulates is the why behind every publication, advocacy campaign, or conference submission that is overall tied to this project. What it does is it ensures that all dissemination efforts, no matter the format or audience, remain focused on 5 powerful and timely messages. 1, collapse of the CDC infrastructure equals urgency. This initiative is poised as a rapid local response to the dismantling of the CDC Division of Blood Disorders. So as I talked a little bit earlier, the national surveillance tools like community counts, which were part of the CDC's divisions of blood disorders, they were cut on April 1st, 2025. So that removed this program from tracking and following the people with bleeding disorders, and removed tracking complications, inhibitor development, which is an important component of medical oversight for how we treat hemophiliacs going forward, treatment patterns, and outcomes through hemophiliac treatment centers. When longstanding tools like this are ripped away from us, the necessity of adaptation can result in scenarios where, for example, the schools must now step in as frontline identification points, setting the stage for compelling, time-sensitive rationale for funding and adoption. This is not the way we would all want it to happen, but this is the way we have to do it. This is the most relevant approach to it in the absence of the CDC's blood divisions. Two, schools are a novel diagnostic platform. This reframes school nurses as reactive care providers to proactive agents in rare disease surveillance, emphasizing a first of its kind early detection model, boosts innovation appeals, and touts this program as one ripe for future expansion across disease categories. May I remind you that when you total up all rare diseases, 1 out of 10 people has a rare disease. That's not that rare. So, I'll be honest, I also biasly think that this initiative could work for a whole host of diseases. We often overlook the value of clinical suspicion, but many high contact point, but less than fully credentialed healthcare providers possess. These school nurses see these kids a lot, and their clinical suspicion is absolutely worth something. So schools as a novel diagnostic platform, number two. Number three, cost savings through early intervention. I'll go into this one a little more because it has its own space, but for the here and now, this section demonstrates that diagnosing early avoids hospitalizations, surgeries, and long-term complications, something that is not only clinically sound practice, but also financially forward thinking. And this section draws heavily from established data from HTCs, some of their regional funded networks, but all of which are in the foundational background section and just total up to the overall fact that we save a lot of money in healthcare by actually early prevention and screening. Four, alignment with national equity goals. This links the project's mission to the HRSA and CDC goals, sadly, especially pre-RFK goals, focusing on underserved and rural populations. So this elevates it from a regional and statewide pilot to a federally relevant model that fills a dangerous surveillance vacuum. And lastly, five, clear advocacy pathways that offer plug-and-play language for stakeholder calls to action, from restoring federal programs to supporting local school-based efforts. It's built to power immediate engagement, especially during advocacy cycles or legislative windows. And in short, the strategic framing section ensures every output carries a cohesive narrative with it, whether the end product is an academic poster or a meeting with a state senator. So all of this keeps the project tethered to national level urgency while reinforcing the local sustainable solutions that the folder lays out. It really just tries to tie it across all of those realms. If you want a quick reference for the strategic framing section, down at the bottom, I think of this main one here. This is where I had this, right? Yeah, shows a very basic key messaging points, what reference documentation within this folder best supports that message point or otherwise best addresses the public health issue associated with that strategic pillar. So here's the quick version. Here's the expanded version. Everything is cross-referenced, just like throughout this folder. Nothing is just sitting out here in a void with nothing backing up, a claim or anything like that. So all interconnected. All right. Now we get our way into arguably one of the most important parts, as if this has not already all been important, the cost avoidance and system impact justification. So what this does is this links early detection to massive long-term healthcare savings. This is the way that I think we broadcast this to a lot of public health officials. This is a behemoth of a section, but it's also one of the strongest levers for persuading state agencies and funders. This section builds an economic and clinical argument for why early school-based identification of bleeding disorder is not just medically urgent or ethically aligned. It's a true financial necessity to do this. It really is. We start again with a hard truth we already know at this point. Diagnostic delays, especially among menstruating adolescents, drive up ER visits. They lead to misdiagnosis, unnecessary surgeries, high healthcare costs, and long-term chronic care needs. Median delays from first bleed to diagnosis in conditions like von Willebrand's disease are over 14 years. That's over a decade of untreated symptoms, avoidable suffering, and compounding public costs. This initiative interrupts that delay at the earliest possible point, the school nurse's office, by giving these nurses the tools to identify, refer, and support students before costly emergencies or irreversible changes take place. God forbid. The cost modeling is clear. A single ER visit for an uncontrolled bleed can cost between $3,000 and $10,000. Unwarranted and otherwise preventable hysterectomies due to misdiagnosed bleeding can cost between $10,000 and $20,000 per surgery. And chronic anemia from undiagnosed bleeding disorders contributes heavily to school absenteeism, cognitive delays, and workforce underachievement. Meanwhile, the actual cost of intervention, like period packs, referral tracking, school nurse stipends, are extremely modest. Furthermore, we can connect students to HTCs, and early study shows that by doing so, we can reduce lifetime healthcare costs by over 40% through better management, fewer hospitalizations, and coordinated care. This model isn't just about saving money, it's about building resilience in families, schools, and healthcare systems. It improves educational outcomes, stabilizes household funds, and strengthens local healthcare infrastructure, especially in rural and underserved areas. In an era where federal surveillance, like community counts, have been dismantled, this is one of the few remaining public health strategies that offers a scalable, equitable, and evidence-backed path forward. So, within this document, if you go into key financial and clinical impacts of diagnostic delay, go into this. There's another small literature review on its own because this is such a key component of this overall initiative. And this is not just because it's a pivotal part of the entire initiative. It also helps my publication strategy down the line, but it's really here because this is an important part. These are humans. And in medicine, we often find ourselves talking too abstractly for too long or remain up in the clouds with our epidemiological data considerations. And we sometimes forget that we are talking about humans, human lives, and impacts to the human experience these individuals go through. A 14-year diagnostic delay is not just a number with a cost associated with a misdiagnosis. It's not just a number, another number. It's a situation we want to get rid of because we're trying to fix the psychosocial impacts of a 14-year time span going through that without a diagnosis. The feeling of a young girl not thinking she's normal, a family petrified with fear because they cannot afford an ER visit but do not understand the severity of their young child's bleeding disorder, a woman having an endogenous part of her body taken away from her, and with it the opportunity to have children. That's why we're doing this. Yes, we're saving some money. Yes, we're getting some diagnosis out of it, but that is why we are doing this. These are people, and the small literature review tries to appropriately frame that in a humanizing way so we never distance ourselves too far from the people we are helping, the true life-changing care we are providing, the horror stories we are preventing, and the life worth living that we are creating out of the ambiguity that so many young girls and their families are faced with. The program level, yeah, that's what this is. That is the key here. Again, very small literature review, well cited, so you know that I'm not just coming out of left field with this. Again, a small summary of it here. Needless to say, I will also be collecting case studies, just like the Eastern and Western Pennsylvania Bleeding Disorders Foundation did. That helps solidify this entire initiative with narratives from the families whose lives it actually changes, right? So this is our program level cost avoidance. And this model breaks down how a small school-based initiative like $5 kits or modest nurse incentives can prevent massive downstream costs from ER visits, unnecessary surgeries, and untreated anemia. It quantifies both individual savings and community-wide economic gains. In short, a low-cost, high-impact model to protect adolescent girls in the absence of federal safety nets. Right, so we talk about, these kits costing $570 per kit. I talked about how we might be incentivizing nurses anywhere between $15 and $250, pretty minimal costs, all things considered, compared to the $232,000 in preventable ED visits in before girls are diagnosed. Misdiagnoses don't just do harm, they hemorrhage public funds. It's not just a hypothetical, it's a documented path from classroom to operating room. Right? These are the true reasons we're doing this, and I want to make sure that we never distance ourselves too far from these. Okay. That's our program level. I think I got us through this. Again, this one is a absolute beast. Strategic justification for policy stakeholders, right? This, again, a little bit more important of why we're working with each of these people, why this is a good public health intervention, why equity and rural access is its own argument unto its own. My goodness. And the long-term health impact. So again, I don't want to bore you all with the numbers behind that one, but that is a really, really important one. All right, and we find ourselves pretty critically at the REST guideline integration. So what I wanted to do here is, this is arguably in the foundational material stuff up above, and it could have been placed there very easily. It appears here very intentionally because I want it to be its own pillar because it crystallizes exactly how we're validating the clinical and economic value of this initiative. So for any of you who really wish to dive into the details of how this study is structured, this REST diagnosis is a very critical part of it. So This is another place where I'm gonna toot my own horn and say I have this project buttoned up in a peer-reviewed, evidence-backed, and precedent-setting science. By adapting this internationally recognized reporting studies on time to diagnosis, REST, guidelines to a school-based setting, we can ensure that this project is more than a well-meaning intervention. It becomes rigorously structured and is thus an easily replicatable diagnostic model for rare disease detection in youth. Um, Again, in a landscape now defined by the loss of CDC surveillance and a widening diagnostic gap for bleeding disorders and plenty of other rare disorders as well, this REST-aligned framework offers a transparent, credible mechanism for measuring impact. Really cool study, actually. Again, one of the few places I encourage you to read it yourself. What I did here is just have a summary of it, a little easier to go through. Because what it does is it bridges clinical metrics, public health surveillance, and educational systems data in a way that no current program is doing. And especially in a way that is not only going to require a few minutes from the school nurses per month. Again, I don't need some crazy bit of data from them. Ultimately, what it does is it reinforces the project's dual function, delivering frontline diagnosis and producing generalizable knowledge that can shape policy, funding, and national standards. This is not just how we're going to track outcomes. This is really how we prove that the model works, why it's scalable, and where it can go next. Again, REST diagnosis, very specific. So my question, you could just rest assured, no pun intended, that my questions in my surveys are aligned with the REST protocols and thus technically reproducing part of their results. And this is really important in rare disorders because, again, time to diagnosis is the key way that we are looking at overall public health cost and impact. Okay. And then lastly, I have some quick grant language just sort of typed in here. That was for Ashley. But it's just here for copy and paste purposes or just a quick synopsis. And then lastly, we'll get into the stuff I have under current construction or am kind of waiting for interdisciplinary input on. Yeah. But before I even get into that, let's do a really quick aside one more time here, because it's a really important component of this that I want to emphasize here at the end. Let's do a quick aside about the data. We might only identify a handful of students with bleeding disorders in any given year. Let's just be realistic, just like the original Pennsylvania study. That's not a failure. That's clarity. Because what this program also does is it uplifts two massive, quietly neglected public health needs. First, it financially and structurally supports school nurses, one of the most overextended and under-recognized workforces in pediatric health. At this point, 65% of U.S. public schools even staff a full-time nurse. Think about, I'm sure most of y'all grew up with one. I surely did. And that number drops down to only 55% in rural areas, with school nurses often straddling multiple schools. And second, it directly addresses menstrual equity, giving students the basic resources they need to participate fully in school and life. Nearly 1 in 4 U.S. teens report they struggle to afford menstrual products. 2 of 5 admitting to using menstrual products longer than recommended because they could not afford replacements. And 75% of Americans would support an initiative like this because they support the fact that they think schools should have free menstrual products. Yet only half of states actually mandate that. And you can only imagine what amount of those schools actually enforce it. Call it as it is. By providing period packs, we are directly reducing period product inequities. That's what it is. By offering small nurse stipends, we inject much needed funding into an overburdened workforce. So yes, the heart of this project is the early detection of bleeding disorders, but it also doubles as a strategic intervention for critical, ongoing public health. End scene. All right, a couple things that are done really quickly as if they matter too much. Like I said, talked about earlier, centralized dashboard, the actual designing of certificates of leadership and diagnostic equity. I love this idea. I've talked to Ashley a lot about it. It's a fantastic idea. I just, in my pragmatic heart of hearts, believe that we need to work on a financial incentivization strategy for these school nurses first, especially because I need the data from them. We need the data from them. California needs the data from them. The many undiagnosed girls out there in this world need the data from them so we can make changes and be able to justify why this is worth it. However, this is an important component, as is talked about a little bit throughout the literature, throughout this folder that I didn't go into, about how we can create some of the we can allow some of the school nurses to have slightly more autonomous roles, maybe even leadership roles. Maybe they're helping facilitate the distribution of period packs in their school district. Maybe they straddle 4 schools, and so they're going to be leading 4 schools. There's a number of important factors to kind of iron out before we decide exactly what specific incentives work best for our population. But designing certificates of leadership in diagnostic equity is a great idea because these school nurses are looking for validation in the ways that they absolutely deserve it. And if they're paying attention to their students, making referrals, doing a good job, giving out period packs, even to students that are not getting diagnosed, we should find a way to reward that. And then probably the biggest behemoth that remains on the table is to actually develop the webinar and training content, right? Because we need to inform the school nurses, what are you looking for, right? So some online-based educational materials we've talked about a lot in meetings so far. There's a number of ways to go about it. The Hemophiliac Foundation Alliance, I should know that, but we're just going to put this in here genuinely that I don't. The HFA has a lot of learning resources. So we might be able to see if we can adopt some of those, or we can absolutely come up with those on our own. I'm a medical student and I'm more than happy to do that. There might be some places where it's good to have a female teaching some of this educational comment. We'll kind of figure out some of that as it goes. My hope is that some of the individuals watching this, as this folder in its current form, are the medical advisory board that will inevitably help me decide what the best way to go about this is. And I will happily defer to their judgments and everybody else's with that matter. So my closing point being, this is a good program. I have rigorously set this up, and this will work if we implement it well. I have nothing but confidence in that fact. But with that being said, I'm a student. I'm open to learning. I am happy to have anybody's insights or critiques on any facet of this folder sent directly to me. I'm not exactly sure how we're going to be disseminating this to everybody, but you'll have the folder. You will have my email, and I am more than happy to make changes to this as we all see the value in it and how it could best be brought to the masses and really do the kind of good that we all both know that we can do doing this and the good that needs to be done because of the current medical landscape. With that being said, I appreciate you watching. If there's absolutely anything else I can do, any questions, comments, concerns, hopes, fears, dreams, I've got time. This project is my baby. Even though I've got a lot going on, I am more than happy to spend the time to make the changes that will get this to the place it needs to go so we can help the people that need help. Thank you very much for your time. I appreciate it. And hopefully we will talk soon.